Our current understanding of how PARP inhibitors work is that they essentially freeze the PARP1 enzyme at areas of DNA damage on the helix. And so when the replication fork hits that physical obstruction, normally it causes a double strand break, and that normally gets resolved by the homologous recombination pathway, which is a very complicated pathway, but clearly, BRCA1 and BRCA2 play important roles there. And so if a cell is deficient in that pathway, and the most profound deficiency comes from having a BRCA1 or BRCA2 mutation, then those double strand breaks can't be resolved, and the cell eventually dies. Now, what that means is that you're sort of looking at PARP inhibitors in a sense as not exactly replacements, but often in the same kind of therapeutic context that you would use, for instance, a platinum, because platinum-based agents also cause inter and intra-strand cross-links, and so double-strand breaks, or a topoisomerase 1 inhibitor, which actually tends to cause the same type of double-strand break through slightly different mechanism. So when it comes to therapeutic replacement, you're kind of thinking about it in those same roles where you would use either a platinum or a topo-1 inhibitor, including potentially an ADC with a topo-1 payload. And it also means that combinations with those kinds of agents are really problematic. So in other words, trying to use a PARP inhibitor along with a platinum simultaneously, or along simultaneously with, for instance, a topo-1 ADC is really infeasible. It's just too toxic from a heme perspective. There are potentially ways to sequence. And so, for instance, there have been a number of studies. The most recent one that was reported at ESMO was KeyLink, which was a study looking at triple negative patients, doing a standard gem-carbo pembro induction, and then randomizing patients to either continue with gem-carbo or go ahead and use olaparib in place of the gem-carbo. And although it didn't show any superiority to the olaparib arm, it didn't show dramatic inferiority either. And so instead of continuing just on for a long time with platinum-based therapy, you could potentially replace it. There have also been some studies, some kind of phase 2 types of studies done trying to combine with ADCs, like, for instance, sacituzumab. And while you can't necessarily give them simultaneously, an approach has been taken to give the sacituzumab, and then after a delay of several days to start the PARP inhibitor, at least in theory, to try to increase the amount of DNA damage or prevent repair from what's caused by the topo-1 inhibitor. And while it's not clear that those strategies are necessarily better than just using either agent in isolation, it certainly is work that's being done to try to enhance the combinations. It's an interesting, so because the PARP inhibitors cause so much genomic disruption and double-strand breaks, the thought has always been that that could enhance, for instance, neoantigen presentation and therefore immune reaction, and that if you simply combined with with a checkpoint inhibitor, that you might be able to take advantage of that. So far, the studies have not been dramatic in the sense that they haven't shown qualitative improvements in responses. The one that's perhaps the most mature is a study called MEDIOLA, which was a combination of olaparib and durva. And in that setting, it didn't appear that there was dramatic improvement compared to what you would expect to have seen in olaparib alone, although obviously it's not a direct comparison. And so one has to take it all with a grain of salt. So I think we'll see. Obviously, combinations with checkpoint inhibitors are interesting for all kinds of reasons. They're clearly safe in that there's no evidence of increased toxicity from the combinations, but whether or not they are meaningfully better than, for instance, a PARP inhibitor alone remains to be seen. I think that what people are trying to do is extend the reach of PARP inhibitors beyond the setting of, for instance, a germline predisposition. I mean, we know that when you have a germline BRCA1, BRCA2, and although we haven't mentioned it, PALB2 alteration, the cancers that arise in those patients usually have loss of heterozygosity of the normal allele. And so there's fundamentally no BRCA or no PALB2, for instance, and that generates an almost complete deficiency of homologous recombination. There are other settings where homologous recombination is impaired, but perhaps not completely abolished. So, in certain settings for triple negative breast cancer, for instance, there may be promoter hypermethylation of BRCA1, and that can result in decreased expression. And some of these epigenetic strategies are trying to essentially take advantage of that by further reducing, for instance, BRCA1 expression even in a setting where there's not a germline mutation. That's been done with some BET inhibitors. This one is a slightly different agent that's attacking the axis in a different way. It's not entirely clear how it improves PARP efficacy, but it has done so preclinically. I think the challenge is that we don't quite know how bad homologous recombination has to be before you get responses to single agent PARP inhibition. And so, for instance, in TBCRC48, they were looking at somatic alterations of BRCA1 and BRCA2. And while you did have meaningful overall response rates, they weren't necessarily what you would have seen in the setting of a germline alteration. And so, and this is the same thing when it comes to doing HRD measurement using various somatic assays, is how bad does it have to be before a PARP inhibitor will work by itself? So certainly there's a lot of work going on in this space, trying to improve the efficacy of PARP inhibition, particularly in the setting of wild-type germline. But so far, I don't think we've kind of hit the magic bullet. I mean, I think there's a lot of work going on biomarkers for immune response, and certainly I think that will eventually help guide the use of a checkpoint inhibitor. And so if there's a setting where you're also wanting to use a PARP inhibitor, then obviously that should improve the efficacy of the combination. I think that's not necessarily going to be specific to the combination of a PARP inhibitor with a checkpoint inhibitor, right? I mean, you're finding out why the checkpoint inhibitor works and the PARP inhibitor is kind of along for the ride. I think the area where we're trying to find biomarkers for PARP inhibition is what I was mentioning before, is somatic measurements of homologous recombination deficiency. And there's two different problems. One is kind of what is the appropriate level of deficiency to confer sensitivity. And the other is that homologous recombination deficiency is a dynamic process. So in other words, you can be homologous recombination deficient. You can accumulate all these genomic scars, which are what are measured by these assays. And then something can happen to actually reestablish homologous recombination. So for instance, a reversion mutation, but you still have the scars. So, the measurement of the scars is kind of the history of what's happened with homologous recombination in a cell. But whether or not that means that the cell is still homologous recombination deficient or the cancer is still homologous recombination deficient, we don't have a good dynamic assay yet. There is one, which is a RAD51 focus assay, but it has not been widely distributed so far.
Find more.
Trying to, and it's hard to find a good dynamic assay is the problem. It's hard to find something that you can measure, for instance, on an FFPE slide that is a clear indicator of that particular cellular process. And so the RAD51 assay is essentially looking at localization of RAD51, which is one of the proteins that's pulled to areas of double-strand breaks in the setting of intact homologous recombination. So if you don't have RAD51 foci, that means that process is out of whack. But so far, we haven't been able to find anything else that's sufficiently specific. Right, so there are two different circumstances where this comes up clinically all the time. One is in the post-neoadjuvant space. The Olympia trial demonstrated significant benefit, including an overall survival benefit to the use of a year's worth of a PARP inhibitor after neoadjuvant therapy in a couple of very specific circumstances. One was triple negative with residual disease, and the other was hormone receptor positive with a fairly substantial amount of residual disease. And so the choices here in the triple negative setting are, do you continue with capecitabine or do you flip over to a PARP inhibitor? And my own opinion on this is that in all of the metastatic trials, the PARP inhibitors were substantially better than capecitabine in terms of overall response rates. And we also know from studies like the ECOG trial, for instance, that although CREATE-X showed a substantial benefit to capecitabine in a truly basal population, it performed extremely poorly with, you know, in the neighborhood of 51% invasive disease-free survival rates at 3 years. So I think in the triple negative setting, using a PARP inhibitor over capecitabine makes more sense to me. As I mentioned earlier, it's perfectly safe to combine it with checkpoint inhibitor, so you can continue the pembrolizumab and just use the PARP inhibitor, and so that is my approach. In the hormone receptor positive space, then the question becomes, well, do you use a CDK4/6 inhibitor along with endocrine therapy, or do you use a PARP inhibitor? And there is some preclinical evidence that, and actually some real world evidence as well, that cancers in people who have homologous recombination deficiency, usually due to a germline mutation, do not appear to do as well with a CDK4/6 inhibitor as patients who have wild type. And as a matter of fact, the benefit may be about half. And so my general approach is to go ahead and use the PARP inhibitor for a year in combination with something like, you know, an aromatase inhibitor or, you know, ovarian suppression plus an aromatase inhibitor. And then after the year, start a checkpoint inhibitor, a CDK4/6 inhibitor at that point, because both Monarchy and Natalie allowed one to start the checkpoint inhibitor at some period of time after the initiation of endocrine therapy. And so you can take this approach and essentially get both agents in. You cannot give them simultaneously because of overlapping myelosuppression. In the metastatic setting, the same question comes up. You know, do we use a PARP inhibitor? Do we use, for instance, platinum in the first-line therapy for TNBC, or now perhaps sacituzumab or an agent like that? And I think somewhat that depends on clinical situation. You're fundamentally approaching the same problem, right? As I said earlier, whether you use a PARP inhibitor or you use a topo-1 inhibitor, you're attacking the same weakness. And so, although there's not great data about ADCs in patients with BRCA mutations, there's absolutely no reason that they wouldn't be effective, and we already know that platinum is. So if you have a scenario where the clinical situation is not particularly dire, then using a PARP inhibitor first probably provides the best toxicity benefit ratio. On the other hand, if you are in a situation where you have a lot of concern, then starting with either a topo-1 payload or a platinum seems perfectly reasonable. And then if you get a good response, you could take a key-link approach and maintain that with olaparib thereafter. In the hormone receptor positive space, as I mentioned earlier, there's some evidence that that patients who have germline mutations are derive less benefit from CDK4/6 inhibition. And there's actually a study called EVOPAR going on right now, which is randomizing patients who have hormone receptor positive disease in the setting of a germline or somatic BRCA alteration to either start with a conventional endocrine therapy CDK4/6 approach, or to start with a PARP inhibitor. And so we will see which approach winds up being better.